recognition and difficult tests.
You think when they
just make it about 2 or 3. AFib and emergency epidemic. It was started by AFib and emerging epidemic, and the community hospital next to the type of recognition.
Sorry, we switched them around. It's getting me confused too. So I'm going to talk today about using an evidence-based approach to managing atrial fibrillation, which is, which I like to describe as our emerging next epidemic in cardiovascular. And so we'll discuss the prevalence of AFib, and I think that's been talked about quite a bit. Discuss a little bit about the use of CHADS-VASc in a large data set and how we're working on that. Use what I call wraparound services to try to get better outcomes for rhythm management for atrial fibrillation. And then discuss a little bit about times before. This is made in 1995, and this is now 30 years later. This bump in population is now moving into the AFib-prone years, and it's expected that atrial fibrillation prevalence or incidence will double over the next 20 years. What this does not take into effect is two things. One is that our population is aging, the life expectancy is getting longer. And the second is that some of the risk factors that promote atrial fibrillation, like obesity, have also increased. And so our prevalence of atrial fibrillation will probably actually be worse than what this was estimated. So just as a quick aside, I'm just going to point this out. This is something you may see more and more of when we use our patients. It's a cardia monitor. It's a little, can be placed in the back of your phone, like mine right here, and it can actually record an ECG strip, as we proved that last night here in Egypt. It is quite helpful in terms of managing patients with a variety of health systems. And I just pointed out because I think that it's not a huge price for patients to approach. And I find it one of the best apps, medical apps out there. CHADS-VASc scores you're well aware of is a scoring system we use to determine who would best be suited for anticoagulation. And what I would like to point out, what we try to do with this now is in our computerized, our electronic medical record now, we use a scoring system for CHADS on all patients with a diagnosis of AFib. And we initially rolled this out so that everybody who's seen by a cardiologist would have to initiate a CHADS-VASc score in the chart, and that then would be correlated over time with the use of anticoagulation. And we just started this in September. And the first thing we found out was that about half of our patients did not get a CHADS-VASc score. And what we found out as we did this was it was not because half of the patients were not seen by cardiologists that had a diagnosis of AFib. So we had to re-roll this out so that all the medical staff does this. So in fact, when we think we're seeing a lot of AFib in our patient population, we're only seeing half of it. And that was in just in 1 month, 236 patients. So and this is only a hospital, a 300-bed hospital. So there is a lot of atrial fibrillation. We know from multiple studies that there are adjuvant therapies for the management of atrial fibrillation that are very effective. Everything from controlling blood pressure, treating sleep apnea, weight loss, exercise, improving exercise capacity, and reducing alcohol consumption. In our own institution, what we did was meet with the people who run the sleep lab, our primary care doctors that manage hypertension. We met with our weight loss, we have a weight loss clinic, and we embedded a dietitian into our atrial fibrillation clinic. We set up with the cardiac rehab an exercise program with the goal, as you've talked about, endpoints of increasing 2 METs of exercise capacity, and then also along with the dietitian talked about alcohol consumption, because we know that all of these interventions are very effective in terms of controlling fibrillation. And then finally, this is put into our clinic to wrap around Now, I just threw this up here because chocolate's good for everything. I'm not sure. It's one of those evidence-based. But we set up an atrial, again, trying to take the things that we know from evidence-based medicine that work and wrap them around, because we know that atrial fibrillation isn't just a disease of arrhythmias, but there's a lot of other issues involved here, and wrap them into an atrial fibrillation clinic. And what we have is a primary nurse practitioner, or physician assistant, who sees patients on Monday, Wednesdays, and Fridays, and actually goes over these interventions and makes sure that each of these pathways is taken care of, along with rate control. And this provides patients that are seen in the emergency department with new onset atrial fibrillation to be seen right away. It again gets us into the wraparound clinic. So we actually set up another arm of this, which is our coagulation clinics, which in the past have been used for Coumadin management. But as you know, at least in our area of the country now, about 65% of people have migrated from Coumadin to novel oral anticoagulants. But that doesn't, but there's still an issue with the use of novel oral anticoagulants. And looking at retrospectively, there are several studies that have shown that about 25% or more of people are not either taking them correctly or not taking them at all, or are inappropriately dosed because of renal function. So we've actually re-established the role of the anticoagulation clinic to have a patient meet once a year with our anticoagulation nurses to go over their renal function, make sure they're taking their meds appropriately, they can afford them. It's a very big issue in the United States because they're very expensive, and they're not stopping them for nuisance, we call nuisance bleedings, like bloody noses, or a bruise in the arm that they don't like. And finally, introducing the concept for those patients that are having significant bleeds, reproducible, to Watchman and other interventions when they can't take anticoagulants. So catheter ablation is a big part of our therapy, and the reason is because it's effective. It is better than any, both in persistent as well as in paroxysmal atrial fibrillation. There's one trial for persistent where it is superior to medical management. And so we're pretty selective, and we're in a very conservative part of the country. So our patients tend to try multiple medical therapies before getting the catheter ablation, but that eventually they'll come to it. As you know, the mainstay of the therapy is isolation of those pulmonary veins, and this is an example of fibrillation going on in the pulmonary vein with electrical isolation in the sinus rhythm. Now, what I'm going to briefly talk about is a little bit about our approach. This is a three-dimensional electroanatomical map of the left atrium, and on the left is the pre-procedure voltage map, and on the right is the post-procedure voltage map. And as you can see, there's the four pulmonary veins here, the left here and the right here. And there's quite a bit of electrical activity and extending up into these, into the pulmonary veins and in the atrium. Based on a couple of, this is a patient who had persistent atrial fibrillation. Based on a couple of pieces of evidence, we've evolved our approach to this type of ablation. We do a couple of things. One is that we take a very wide encircling. So as you can see, if you wanted to know what the definition of the atrium, I would say it's these bulges that extend down into the posterior wall. That's the atrium. And we know that from several studies that a wider area lesion is more effective than right at the osculum of the veins. Here, the second line of evidence of why we do this wide area encircling lesion, or the whole posterior wall, in fact, is based on the pulmonary, the patients with atrial fibrillation that had lung transplants, and that by placing the lung transplant, but they'd have to section out the posterior wall here to attach the pulmonary veins, and there's a lower incidence of atrial fibrillation. The third line of incidence was our experience with epicardial ablation with with the surgical approach, combined with our surgeons, which is the in-contact system. In that approach, the surgeon would get epicardial access from some xiphoid approach on the endocardium, ablate this whole posterior wall here, as well as around the veins. And then we would come in afterwards with catheters and finish off pulmonary vein isolation. Often with those approaches, we found that there, even despite ablation in the posterior wall, there would be leaks across the roof, and we would have to complete a roof line. And we found that in those groups, and that was a pretty highly selected group of persistent AFib, so that I'm going to stop this first. I guess I can't stop it. This group, we had a great success in terms of managing their rhythm. So our approach now is to do wider encircling lesions around both groups of pulmonary veins, here and here, and then connect a roof line and a posterior left atrial line. So back here. So we call it block in the box. So we got both entrance and exit block in the pulmonary veins there. Now, one of the biggest limitation of this is esophageal, potentially esophageal injury. And to do this, we're very cautious about what we do in the posterior wall. We put a circa high definition temp probe in the esophagus. We use a very low threshold, which is 38 degrees. Any temperature right of 38 degrees is immediate termination of ablation. And we use an esophageal, now we use an esophageal deviator, the esophageal, which allows us to deflect the esophagus out of the way. So with those, we have never had an esophageal fistula, but we have had times where we've not been able to complete, let's say, a posterior line because we just cannot get any rise in esophageal temperature. One of the things I'll also mention about this is, we all work about breakthroughs in the AFib. By placing this posterior line in the roof line, if there is a breakthrough in the posterior wall here, we've got it sealed off from below. So what I will tell every patient I see is we do not, right now, as of 2017, cure atrial fibrillation. And this is an example of somebody who's got a 5 ICD in place, and their ablation was right here at the line, and you can see going out 2 years, these little blips are just little, atrial prematures and not any tachycardias. But he had 8 hours of atrial fibrillation one night, and then went on again, not to have any atrial fibrillation. This is not a cure, so we don't misinform patients that we cure atrial fibrillation this time. Now, is this patient's quality of life markedly improved? Yes. Is he back to work? He was a car salesman. He's back to work. He's not limited. This occurred at night. He didn't even know it. So yes, it's much improved quality of life from what we do not cure atrial fibrillation. Now, our own experience, I moved institutions, and so I had to restart this. So this is a little over 2 years of data on atrial fibrillation ablations since July of 2000, August of 2015, till September of this year. But it in some ways mirrors what we had experienced for the previous 4 years. It's the same database, but then it has some other interesting things. So about 60% of our patients are male, present with atrial fibrillation ablation. The type of, I said, is a very conservative environment. So that whereas before it used to be about 50-50, 50% paroxysmal, 50% persistent. In this group, we're almost 70% persistent, another 8% long-lasting persistent. These are people who have had atrial fibrillation for over a year in duration. So just 22% are paroxysmal. So where Stefano had earlier mentioned it's good to get these patients early, we're unfortunately seeing these patients later, and it has to do with being the medical environment and people being very conservative. Nonetheless, and then the comorbidities are like you would expect, a lot of hypertension, heart failure, and then a smattering of every other cardiovascular disease based on age and population. They're not, from a left atrial side, left atrial mechanism side, they're not healthy patients. They tend to be large left atriums with big volumes, and then they're very interesting. We see a lot of people with high multiple Ps. In fact, in this population, 2 of our patients had amyloidosis that we picked up only because after the fact, when we went in and saw this, their LV function was normal on the rectal, but when I find an LV EVP or left atrial pressure 25 or 26, you have to start looking for something else and why it's such a restricted disease. Because they're mostly persistent, we're using mostly radio frequency. Then the rest of most of the paroxysmal will take rate to cryo, but add RF for flutter lines and other things that will induce after pulmonary vein isolation. Our repeat procedure rate is 12%. It's a little bit less in paroxysmal, a little bit more on the persistent. Interestingly, the long-lasting persistent haven't required any repeat procedures yet, but those are usually the most likely to have repeat procedures. I looked at this and compared to the previous 4 years data. It used to be it was 16%, so we've dropped that by being more consistent about our posterior box. Complications, and this I think is the reason why this isn't we're not as forthcoming in using this as easily as drugs, because there's always a price to pay for this, and of course. Hematoma is more common because people are on anticoagulation. And the interesting thing is most of our hematomas are occurring after they leave the hospital. The next 2 days or so, then all of a sudden they develop a hematoma, which I think is related to some of their activity in the early discharge that we do. And we've had tamponade, of course, chronic nerve injury. Fortunately, these have all resolved. We've had no deaths, no esophageal injuries, and no pulmonary vein stenosis to this point. Outcomes. 80% at 6 months, above 80%, and these 10% are additional 10% we get with meds, so we're up over 95% are sinus rhythm. It's a little fall off at 18 months, but at 24 months we're still, this is a little bit overinflated. This is where you're starting to see where the medial procedures come in, where we can bring that up. So we're pretty happy with our results. I think our real focus is in every day for us is patient safety. An interesting group of patients that I'd like to point out is our patients with heart failure. We get a lot of patients with heart failure with atrial fibrillation. In our group, we had about 20% had ejection fractions less than 50%. The mean, the mean EF is 32. And about 55% of them normalize their ejection fraction after return to sinus rhythm, with another 10% improving. And as you'd expect, there's going to be that 30% that are in ischemic disease or fixed disease. It's not going to improve. But so I think there's a real value here for patients with symptomatic heart failure that have left ventricular dysfunction in terms of rhythm management. So if I was to summarize, I'd say, of course, AFib is not good for you. You have a higher risk of stroke, heart failure, probable dementia, and definitely death. And then stroke prophylaxis and the CHAS-DAS score. And I think we can do a lot better on that by really taking that. We all say, oh yeah, well, everybody I see I do a CHAS-DAS score. But the thing is that we're not seeing everybody in our own data in our own hospital. Only 50% of the people with AFib are even getting the CHAS-DAS score to even potentially be on anticoagulation. We've identified using wraparound services with nurse navigator, AFib clinic, anticoagulation clinics to provide a comprehensive level of care, which I think is improving our outcomes of our patients. And then finally, I think rhythm management with catheter ablation is a very effective therapy, although it is not curative. Thank you.
Thank you very much.